Hello, future nurses, and welcome to this important session on the nursing care of clients with neurological tumors. Tumors of the brain and spinal cord bring unique and serious challenges because they directly affect the central nervous system, the very control center of the body. Whether benign or malignant, these tumors can alter cognition, movement, sensation, and even basic life functions. As nurses, we play a vital role in early detection, symptom management, and providing both physical and emotional support to clients and their families. In today's lecture, we will break down the types of neurological tumors, explore their clinical manifestations, and review priority nursing interventions, along with high-yield NCLEX strategies to sharpen your critical thinking. Stay engaged, because mastering this topic is not just about passing the exam, it is about preparing to deliver safe and effective care to some of the most vulnerable clients you will encounter. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner NGN questions, broken down in detail during comprehensive lecture. This isn't just another review. It's everything you need in one place. Scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. All right, let us smoothly move into this advanced NCLEX scenario about diagnostic preparation. The question states, a client with a suspected brain tumor is scheduled for a positron emission tomography scan the next morning. The nurse is reinforcing pre-procedure teaching. Which substances should the nurse instruct the client to avoid in the 24 hours before the test? Here are the options. Option 1, caffeine. Option 2, shampoo. Option 3, diuretics. Option 4, shellfish. Option 5, alcohol. And Option 6, tobacco. The correct answers are Option 1, caffeine, Option 5, alcohol, and Option 6, tobacco. Let us now explore the reasoning behind these answers. Caffeine is correct because it acts as a central nervous system stimulant that changes glucose metabolism, cerebral blood flow, and neuronal activity, all of which are directly measured in a PET scan. Even small amounts from coffee, tea, chocolate, or cola can create false readings, so it must be eliminated 24 hours before testing. Alcohol is also correct, since it works as a central nervous system depressant, altering brain metabolism and glucose uptake. Drinking alcohol within 24 hours may reduce tracer absorption and give an underestimation of tumor activity, so abstinence is necessary. Tobacco is another correct option because nicotine stimulates the sympathetic nervous system, causes vasoconstriction, and raises brain metabolism. Smoking within 24 hours can mimic abnormal hot spots, giving false positive results, and therefore must be avoided. Now, let us discuss the incorrect answers. Shampoo is not a factor because hair products have no effect on glucose metabolism or tracer uptake. This precaution is usually related to electroencephalogram preparation, not PET scans. Diuretics may affect fluid balance but do not interfere with glucose metabolism or the radio tracer used in PET imaging, so they are not restricted unless clinically indicated. Shellfish is also not relevant here because PET scans use fluorodeoxyglucose, a glucose analog, not iodinated contrast dye. Therefore, shellfish allergy has no connection. Clinically, it is important to remember that PET scans rely on radio-labeled glucose uptake to differentiate between normal and abnormal brain tissue. Substances that alter metabolism or perfusion, such as caffeine, alcohol, tobacco, sedatives, or tranquilizers, are the ones that interfere and should be avoided. From a test-taking strategy perspective, when you see a "select all that apply" question, focus on identifying the options that directly impact metabolism or neurologic activity and eliminate distractors like shampoo or shellfish. Finally, here is the Stan Coast Pearl. To make it stick in your memory, think of the phrase "no CAT," caffeine, alcohol, and tobacco. These three are the key substances to avoid before a PET scan because they directly interfere with tracer uptake and brain metabolism. Let us now transition into this next NCLEX style question that focuses on discharge teaching after a diagnostic procedure. A client has just completed a positron emission tomography scan for evaluation of a possible neurologic disorder. As the nurse provides discharge teaching, which instruction is most appropriate to include? The options are as follows. Option 1, take a mild sedative tonight. Option 2, increase your fluid intake. Option 3, avoid excessive sitting. And option 4, report signs of a fever. The correct answer is option 2, increase your fluid intake. Here's the expanded rationale to help you reason this out step by step. To begin with, let us understand the procedure. A positron emission tomography scan requires the intravenous administration of a radiopharmaceutical tracer, usually fluorodeoxyglucose, which is a glucose analog attached to a short-lived radioactive isotope. This tracer makes metabolic activity visible, particularly in the brain or suspected areas of malignancy. Although the radiation dose is considered low and safe, it does remain in the body temporarily and must be cleared through renal excretion. Looking at option 2, increase your fluid intake. This is correct because hydration is the key intervention that speeds up renal clearance of the tracer. Clients are typically encouraged to drink 4 to 6 glasses of water in the next 24 hours, which helps flush the isotope, lowers bladder and tissue radiation exposure, and reduces any irritation to the urinary system. This is the universal teaching priority after a positron emission tomography scan and ensures both patient safety and reduced risk of unnecessary radiation to others in close contact. Turning to option 1, take a mild sedative tonight. This is incorrect because sedatives are not required after the scan. The tracer does not cause restlessness or insomnia, and most patients tolerate the procedure without difficulty. Sedatives would only be used in rare situations, such as significant anxiety during the procedure, but this is not routine discharge advice. Now, let us consider option 3, avoid excessive sitting. This too is incorrect because activity level does not affect tracer clearance or patient recovery. Patients may return to their normal activities immediately. The only time rest is important is before the test, when clients are advised to limit movement to prevent tracer distribution in muscle tissue. Finally, with option 4, report signs of a fever, this is also incorrect. Fever is not a usual complication after positron emission tomography. The tracer injection rarely causes infection or systemic reaction. While fever reporting is always good advice in general care, it is not a specific or necessary teaching point here and may cause confusion if emphasized. From a clinical insight perspective, the discharge teaching primarily revolves around hydration and frequent voiding to minimize radiation exposure. Clients may also be told to take temporary precautions around infants or pregnant women until the tracer clears. Otherwise, there are no diet, activity, or infection-related restrictions afterward. For your NCLEX strategy, always prioritize instructions that promote elimination of the tracer or contrast material and reduce risk of complications. Eliminate choices that add unrelated actions, such as sedatives, unnecessary restrictions, or fever monitoring. And here is your Stancoast Pearl. Remember the phrase, flush it out, keep it safe. After a positron emission tomography scan, drinking plenty of fluids and voiding frequently is the #1 discharge priority to ensure safety and effective tracer elimination. Let us move into a critical neurosurgical scenario that challenges your ability to prioritize assessments. A client has been diagnosed with a supratentorial brain tumor confirmed by positron emission tomography and is scheduled for a craniotomy. The nurse is preparing the client pre-operatively, and the question asks, which assessment finding is the most critical to document as a baseline for post-operative comparison? The options given are as follows. Option 1, motor strength in all extremities. Option 2, sodium and potassium laboratory values. Option 3, pulses in lower extremities. And option 4, glucometer blood glucose levels. The correct answer is option 1, motor strength in all extremities. Now let us carefully unpack the reasoning behind this. A craniotomy is a high-risk neurosurgical procedure, and the most feared complications include cerebral edema, hemorrhage, and rising intracranial pressure. Because neurologic status is the earliest and most sensitive indicator of brain function, baseline documentation is absolutely essential for comparison. Recording motor strength before surgery ensures that the nurse can detect even subtle post-operative deterioration, such as reduced grip strength, unequal limb movement, or inability to follow motor commands. Early recognition of such changes allows life-saving intervention. Looking at option 2, sodium and potassium laboratory values are important, particularly since neurosurgical patients are at risk for conditions like syndrome of inappropriate antidiuretic hormone secretion or diabetes insipidus. However, electrolytes are dynamic numbers that can be corrected, whereas a new motor deficit reflects possible structural damage and cannot be overlooked. Turning to option 3, peripheral pulses in the lower extremities are vital for vascular or orthopedic surgeries, but they are not the most relevant marker of neurologic stability after brain surgery. Craniotomy does not usually compromise peripheral circulation directly. Moving on to option 4, blood glucose monitoring is indeed significant because hypoglycemia can mimic neurologic deficits, and hyperglycemia worsens cerebral outcomes. Still, glucose values can be adjusted perioperatively, and they do not provide the same real-time neurologic baseline that motor strength does. Here is the clinical pearl. In post-craniotomy care, the cornerstones are frequent neurologic checks, airway protection, and control of intracranial pressure. Establishing a baseline motor assessment preoperatively gives the nurse the most reliable tool for detecting deterioration after surgery. And finally, remember this Stan Coast pearl. In neurologic surgery, baseline is everything. The single most reliable way to detect complications is by comparing the client's preoperative motor strength with post-operative findings. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lecture. This isn't just another review, it's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us now move into another advanced NCLEX style scenario that highlights both anatomy and safety in nursing care. The nurse is preparing a male client scheduled for a craniotomy and inserts a urinary catheter pre-operatively. Considering the anatomy of the male urethra and the risks of improper placement, how far should the catheter be advanced to ensure correct positioning in the bladder before balloon inflation? Here are the options to consider. Option 1, 2 to 4 inches, which is equivalent to 5 to 10 centimeters. Option 2, 4 to 6 inches, which is equivalent to 10 to 15 centimeters. Option 3, 6 to 8 inches, which is equivalent to 15 to 20 centimeters. And option 4, 8 to 10 inches, which is equivalent to 20 to 25.5 centimeters. The correct answer is option 3, 6 to 8 inches, or 15 to 20 centimeters. Now, let us carefully reason this out step by step. A urinary catheter is inserted preoperatively to maintain accurate fluid balance monitoring, reduce bladder distension during surgery, and prevent post-operative complications. The male urethra is approximately 18 to 20 centimeters in length, so inserting the catheter 15 to 20 centimeters ensures that the catheter tip actually enters the bladder lumen. Importantly, urine flow must always be observed before balloon inflation to confirm bladder placement. Inflating the balloon too early can rupture the urethra, cause pain, and lead to false passages. After urine return, advancing just 1 more inch ensures the balloon is safely within the bladder before inflation. This technique protects both bladder function and urethral safety. Looking at the incorrect choices, option 1 of 2 to 4 inches is far too short for a male client. At this distance, the catheter would still be within the penile urethra, and inflating the balloon here would cause severe trauma and bleeding. Option 2 of 4 to 6 inches is closer but still insufficient for most men, as the catheter may never reach the bladder, leading to absent urine flow and dangerous balloon inflation in the urethra. On the other end, Option 4 of 8 to 10 inches represents over-insertion. While the catheter may still reach the bladder, excess length risks coiling within the bladder, causing kinking, discomfort, and impaired drainage. To reinforce this for NCLEX success, here are some pearls. Female catheter insertion depth is 2 to 3 inches, whereas male insertion requires 6 to 8 inches. Always wait for urine return before inflating the balloon, and then advance slightly to confirm safe placement. Safety priority means never inflating the balloon without proof of bladder entry. And here is your stand coast pearl to carry forward. In catheterization, centimeters count. Too short risks trauma. Too far risks coiling. Correct depth protects both bladder function and urethral safety. Moving on to another important surgical preparation scenario. Imagine a nurse caring for a client scheduled for a craniotomy. As part of the pre-operative teaching, the nurse explains that the scalp must be prepared, which includes partial hair removal. To minimize infection risk, preserve the client's dignity, and maintain strict aseptic technique, the nurse must determine the best time to clip the client's hair. The options to consider are the night before surgery, in the morning after a shower, before administering preoperative sedation, or immediately before surgery in the operating room area. The correct answer is option 4, immediately before surgery in the operating room area. Let us carefully reason through this. Craniotomy is a highly invasive neurosurgical procedure, and infection prevention is critical. Any small abrasions caused during hair clipping can quickly become a site for microbial colonization if performed too early. By clipping in the operating room immediately before surgery, the risk of surgical site infection is minimized, the client's dignity is protected since only the surgical field is exposed, and asepsis is maintained in a controlled, sterile environment. This is also consistent with evidence-based practice, which advises clipping rather than shaving, and only when necessary, as close to the time of incision as possible. Now, let us review why the other options are incorrect. Performing hair clipping the night before surgery, option 1, is outdated and increases infection risk because bacteria have hours to colonize overnight. Option 2, in the morning after a shower, may reduce surface bacteria, but still leaves several hours before the procedure for microbial growth, making it unsafe. Option 3, before administering preoperative sedation, is slightly closer to surgery, but it is still not optimal because the client is not yet in the controlled perioperative sterile environment. The bottom line is that time matters most. Clipping immediately before surgery reduces infection risk, protects the client's psychological comfort, and aligns with current perioperative standards. Here is the stand coast pearl. Time matters most in preoperative preparation. The closer the clipping is to the incision, the lower the infection risk. In neurosurgery, scalp clipping is always performed in the operating room immediately before surgery, never the night before. And finally, a high-yield NCLEX tip to remember. Never shave hair for surgery. Always clip instead, and perform it only when necessary and as close to the incision time as possible, especially in neurosurgical procedures. Let us transition into this next NCLEX-style scenario with a focus on surgical preparation and client education. A client scheduled for a craniotomy asks the nurse, "Why are you clipping my hair instead of shaving it?" The nurse must provide a clear, evidence-based explanation that reflects both safety and best practice guidelines. Here are the options to consider. Option A says, clipping the hair is hospital policy. Option B states, this method is safer for you. Option C explains, shaving the head causes microscopic cuts, which increase the risk for infection. Option D mentions, if your scalp bleeds during shaving, surgery could be postponed. Now, the correct answer is option C. Shaving the head causes microscopic cuts, which increase the risk for infection. This option is the most accurate and evidence-based response because it links directly to the pathophysiology of surgical site infections. During procedures like craniotomy, the skin is the primary protective barrier against bacteria. Shaving with a razor disrupts that barrier by creating microabrasions, which are invisible to the naked eye but serve as an entry point for microorganisms. If shaving occurs hours or even the day before surgery, these small wounds may already become colonized with bacteria, significantly raising the risk of post-operative infection. This is especially dangerous in neurosurgery, where infection can spread rapidly to the central nervous system. For this reason, global guidelines from the Centers for Disease Control and World Health Organization recommend clipping hair instead of shaving, and only when necessary. Clipping trims hair close to the scalp without breaking the skin, maintaining its natural defenses while still allowing visibility of the surgical site. Moving to option A, clipping the hair is hospital policy. This may sound correct on the surface, but it is incomplete. While it is true that most hospitals follow this practice, the NCLEX expects the nurse to provide clients with not just a rule, but the scientific reasoning behind it. By simply citing policy, the nurse misses an important teaching opportunity. Shifting to option B, this method is safer for you. Although this is a true statement, it lacks specificity. It does not explain why clipping is safer and therefore does not educate the client. NCLEX emphasizes precise therapeutic communication, so vague reassurance does not meet the standard of an effective nursing response. Finally, option D, if your scalp bleeds during shaving, surgery could be postponed, is not entirely incorrect. But it is not the main rationale. The central concern in this scenario is infection risk due to microscopic cuts, not bleeding alone. Therefore, although bleeding is possible, it is secondary to infection prevention. Here is the Stan Coast Pearl. Clipping protects the skin barrier, shaving disrupts it. In surgical preparation, preserving the natural skin defense is the strongest shield against infection. And here is the NCLEX tip. Always remember, clip rather than shave. Clipping reduces bacterial entry points, lowers infection risk, and aligns with evidence-based international standards. This principle not only ensures client safety, but also demonstrates professional nursing competence. Let us now move into another critical NCLEX-style scenario, one that tests your knowledge of immediate post-operative nursing priorities. A client has just returned to the surgical unit 6 hours after undergoing an abdominal procedure. During the initial post-operative assessment, the nurse observes that the surgical dressing is moist with a small amount of serosanguinous drainage. At this moment, what should the nurse do first? Here are the options to consider. Option 1 suggests changing the dressing. Option 2 recommends reinforcing the dressing. Option 3 says to remove the dressing. Option 4 proposes documenting the findings. The correct answer here is option 2, reinforce the dressing. Let us break down the reasoning step by step. The immediate postoperative phase is one of the highest risk periods for surgical clients, where infection, bleeding, and wound complications are closely monitored. The dressing in place acts as a sterile barrier that shields the incision from external contamination. According to standard surgical protocols, the first post-operative dressing change is almost always performed by the surgeon or advanced provider, unless there is a direct order for the nurse to do so. By reinforcing the dressing with additional sterile gauze, the nurse preserves the barrier, prevents contamination, and ensures the wound remains protected until the surgical team can evaluate it. Now, let us evaluate why the other options are incorrect. Option 1, changing the dressing, is unsafe because the first change is reserved for the surgeon. Doing so prematurely may disrupt the sterile field and expose the wound unnecessarily. Option 3, removing the dressing, is even more inappropriate, as it exposes the surgical incision directly to pathogens and increases the risk of wound dehiscence. Option 4, documenting the findings, is important but never the first priority when an intervention is required. The nurse must act to reinforce the site first, and then record both the observation and the intervention afterward. Here is your high-yield clinical pearl. In NCLEX-style questions, always prioritize safety and infection prevention in post-operative care. Reinforcing the dressing protects the wound, aligns with Maslow's physiologic safety level, and prevents unnecessary complications. Remember also that if the drainage were excessive, expanding rapidly, or accompanied by signs of shock such as hypotension, tachycardia, or restlessness, the priority would change to notifying the surgeon immediately, as this could indicate hemorrhage. Your final takeaway is simple but powerful. In the early postoperative setting, never change or remove the dressing unless ordered. Instead, reinforce it to maintain sterility and safety. Documentation follows after the action is taken, not before. This principle reflects both infection control and safe nursing practice. Let us now transition into another important NCLEX-style question that challenges your ability to prioritize safe and therapeutic nursing care after neurological surgery. A client is in the immediate post-operative period following a craniotomy for removal of a frontal lobe tumor. During the night shift, the nurse notices intermittent episodes of confusion, where the client attempts to get out of bed without help and seems disoriented to place. The question is, which nursing intervention is the most appropriate during these confused episodes? Here are the possible options to consider. The first option suggests reading a newspaper or magazine aloud to the client. The second option recommends informing the client that the confusion is only temporary. The third option proposes withholding verbal communication temporarily to avoid overstimulation. And the fourth option advises reorienting the client gently and consistently to place and situation. The correct answer here is option 4, reorienting the client gently and consistently to place and situation. Here is the detailed reasoning behind this choice. After a craniotomy, clients are highly vulnerable to complications such as increased intracranial pressure, cerebral edema, bleeding, infection, and postoperative delirium. Confusion may stem from cerebral manipulation, swelling, anesthesia effects, or early neurological decline. Nursing care must focus on maintaining safety, lowering anxiety, and supporting cognitive recovery while monitoring for any signs of deterioration. By reorienting the client to place and situation, the nurse not only helps the client remain connected to reality, but also provides reassurance and reduces agitation. This action prevents unsafe behaviors such as unassisted ambulation, which could lead to falls, seizures, or disruption of the surgical site. Furthermore, frequent reorientation allows the nurse to track subtle changes in neurological status that may indicate early complications. Now, let us take a closer look at why the other options are incorrect. Reading aloud from a newspaper or magazine, as in option 1, may stimulate the client, but it does not directly address confusion or ensure safety. In fact, it may overwhelm a client who cannot process new information effectively in this phase. Option 2, which involves telling the client that confusion is temporary, may sound supportive, but in reality, confused clients are often unable to process or retain abstract reassurance, so this does not correct disorientation or prevent harm. Option 3, withholding communication, removes verbal grounding and can increase anxiety, worsen confusion, and even make the client feel abandoned. After brain surgery, consistent therapeutic communication is essential, not silence. Here are a few high-yield pearls to keep in mind. First, safety and reorientation always take priority over passive stimulation or abstract reassurance. Second, even small changes in orientation can be early red flags for increased intracranial pressure or hematoma formation. Third, according to Maslow's hierarchy, physiological safety and psychological grounding must come before higher-level needs like intellectual stimulation. And here is an NCLEX strategy tip. When faced with a confused client, the best nursing actions are those that promote safety, reinforce reality orientation, and use therapeutic communication. So, the key takeaway is this. The most appropriate nursing intervention during periods of postoperative confusion is to gently and consistently reorient the client to place and situation, because this not only ensures safety, but also aids neurological monitoring and supports recovery. Let us now move into this high-yield NCLEX style question and carefully unpack it so that it flows naturally for a teaching script. A client is in the immediate postoperative period following abdominal surgery. The physician has prescribed a clear liquid diet with intake limited to 1,000 milliliters in 24 hours. Before the nurse requests these clear liquids from dietary services, the essential question is, which assessment must be prioritized to ensure client safety? Here are the options to consider. First, assessing the client's ability to raise the head. Second, identifying the client's preferences for clear liquids. Third, checking for the return of bowel sounds in all 4 quadrants. And fourth, evaluating the client's ability to swallow effectively. The correct answer is option 4, the client's ability to swallow effectively. Here's the expanded reasoning behind this choice. Post-operative clients are at risk for aspiration because of residual anesthesia effects, opioid sedation, or neuromuscular weakness. Although a physician's order may state that clear liquids are allowed, the nurse must first validate the client's capacity to swallow safely, since patient safety always overrides comfort or dietary preference. If swallowing is impaired, even a small sip of water can result in aspiration, leading to pneumonia, hypoxia, or other life-threatening complications. Looking at option 1, the ability to raise the head is helpful for safe swallowing, but it does not confirm that the gag or swallow reflex is intact. Clients may aspirate even when sitting upright. For option 2, client preferences for juice, broth, or gelatin are certainly important later, but preferences cannot be considered until swallowing safety is confirmed. Moving on to option 3, bowel sounds often return gradually after abdominal surgery. While they are important when advancing the diet to solids or full liquids, They do not determine readiness for the first sips of clear fluids. Option 4 stands out as correct because confirming effective swallowing directly addresses airway safety, aligns with Maslow's hierarchy, where physiological needs such as oxygenation take priority, and matches NCLEX test plan expectations that airway and aspiration risks must always come first. Stand Coast Pearl. Always remember, before sip, check the swallow. Even if the order is written, it is the nurse's responsibility to ensure swallowing is intact before giving any oral intake. NCLEX strategy. Tip. Whenever a diet-related question appears, ask yourself which assessment ensures safety before following the order. If there is any possibility of aspiration, the ability to swallow safely always outweighs bowel sounds, head positioning, or client preferences. Let us continue this NCLEX script smoothly with the next advanced level question. A client who has recently sustained a severe traumatic brain injury is placed on fluid restriction. The client looks at the nurse and asks, "Why are you limiting how much I can drink?" This moment calls for both clinical reasoning and therapeutic communication. Here are the possible responses. First, large amounts of fluid may increase your risk of vomiting. Second, your kidneys need to conserve fluid output at this time. Third, restricting fluid prevents extra fluid from building up inside the skull, which could increase brain swelling and pressure. And fourth, the prescribed fluid volume is enough to keep you comfortable and relieve your thirst. The correct answer is option 3. Restricting fluid prevents extra fluid from building up inside the skull, which could increase brain swelling and pressure. Now, let us carefully walk through the reasoning. Clients with traumatic brain injuries or intracranial surgeries are at high risk of cerebral edema. Excess fluid intake increases circulating plasma volume, which in turn worsens brain swelling and elevates intracranial pressure. Elevated intracranial pressure reduces cerebral perfusion, impairs oxygen delivery, and may rapidly lead to herniation and death if not controlled. The nurse must always explain in a way that protects safety and clarifies the pathophysiology. Looking back at option 1, while it is true that excess fluid might contribute to nausea and vomiting, this is not the main reason for fluid restriction in a neurologic client. Vomiting can raise intracranial pressure, but it is a secondary concern compared to the direct risk of worsening cerebral edema. Turning to option 2, suggesting that the kidneys need to conserve output is inaccurate. The kidneys automatically regulate urine production, and fluid restriction in this case is not about renal conservation, but about intracranial dynamics. Shifting to option 4, telling the client the prescribed volume is enough to relieve thirst, dismisses the seriousness of the intervention. Thirst is subjective, and this explanation minimizes the life-threatening risk of brain swelling. Here are the clinical pearls you should keep in mind. Maslow's hierarchy tells us that physiologic safety always outweighs comfort. Therefore, preventing brain swelling is more important than relieving thirst. From an intracranial pressure perspective, every milliliter of fluid counts, as excess volume can worsen swelling and compromise cerebral perfusion. From a therapeutic communication standpoint, the nurse must validate the concern while delivering an accurate, safety-focused explanation. And according to evidence-based practice, neuro-trauma guidelines consistently emphasize fluid regulation as part of ICP management. Stand Coast. Pearl. In clients with neurologic trauma, always connect interventions back to intracranial pressure. On NCLEX, if an answer choice mentions preventing cerebral edema or controlling ICP, that option usually takes priority over explanations focused only on comfort or reassurance.